Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the CEO of this organization. So we have a case presentation today about taking an open tray fixture level impression of a dental implant. So we'll start off with a description of our case. We have patient X, who is a 74-year-old healthy female who presented as a new patient exam at our office, and she presented with no chief complaint or no concerns. So upon routine examination and review of her radiographs, you can see in this panoral radiograph that there are a few areas in which there's some attrition of teeth. There's some areas of caries noted, some areas where there's some teeth with endodontic treatment that have received some cuspal coverage restorations, and you'll sort of see the elephant in the room there, the tooth on the bottom left, or the patient's bottom right. That would be the right mandibular second premolar. There appears to be a significant radiolucency associated with the post-restoration complex there. So we'll take a closer look at that tooth in this bite wing radiograph, and one can see that this tooth has been restored. It's endodontically treated. There appears to be an active post inside the tooth, and for all apparent reasons, that's probably the only thing that's holding this restoration in place. There appears to be some recurrent decay or caries, and basically there's not really much tooth structure remaining here. So upon removing this post and restoration complex, this tooth is going to basically be something which is going to be down close to the gum line. In terms of gaining some sort of a restoration on this tooth, we will be impinging on this patient's biological width. And so traditionally the option in this sort of a case would have been to perform some sort of crown lengthening surgery in order to not impinge upon the patient's biological width and provide this patient with not just a restoration but also a stable and healthy periodontium. However, there are risks that come along with performing any sort of crown lengthening procedure, in the sense that you can't just create a vertical bony defect. You have to actually sort of grade the bone in. And so you'll be taking bone away from some of the healthier teeth. And all in all, this is sort of perhaps a more archaic form of treatment. Perhaps a better form of treatment, or a better treatment option for this patient, would be to consider extraction of this tooth and either providing this patient with some form of restoration in the form of either a 3-unit bridge or a dental implant or some sort of removable prosthesis, may be a better option for this patient. So we'll go to our next screen, which is the treatment plan. And more or less, we describe the situation to the patient and go over all the treatment options and basically go through the consent process. And then the second step is basically to perform sanative treatment for this patient in the form of surgical, restorative, and periodontal treatment and therapies. The patient also appeared to have a fair amount of occlusal wear, and this patient would probably benefit from bite plane therapy so as to take any sort of parafunctional habit that does exist out of the equation. So if we are going to be considering something like expensive restorative treatment like crowns, bridges, that sort of stuff, or even dental implants, that this bruxism habit is not going to cause a detriment to these treatments. We then want to bring the patient back for evaluation and ensure that the causes of disease have been dealt with and this patient's condition is stable, such that we can consider more expensive restorative treatment options. And so number 5 is going to be, in this particular case with this patient, we went through the consent process, and the patient basically agreed that the best option for them would be the removal of the 4-5 and an immediate implant placement with a PRF graft. And we would give this about 4 to 6 months of healing time. And then basically the patient would present for a stage 2 procedure, and a fixture level impression of the 4-5 area and a healing abutment would be placed. And this is basically the crux of this case presentation. We're going through the entire case, but this video is going to be just about how to take this open tray fixture level impression. We're going through the whole case just to sort of give people an idea of how everything goes from gate to gate. And then finally, restoration of the 4-5. And number 9, something which we all seem to forget about, long-term follow-up. So looking at this periapical radiograph, you can see that we're using some treatment planning software to determine the actual width and height of the residual socket once this tooth number 4-5 is going to be taken out. So from this radiograph, we can probably plan for implant that's going to be slightly wider than 4.6 millimeters, and we can go anywhere from 10 to 13 millimeters safely in this case. So this is a radiograph showing the tooth taken out, and in the next radiograph, you'll see the dental implant that was placed. In this case, this was a Implant Direct Legacy 1 5.7 millimeter platform by 11.5 millimeter dental implant. So now we go to the video, and in this video the goal basically here is to perform a stage 2 procedure. So what I like generally doing is doing an H incision. You'll see what I mean by an H incision. And the beauty of this, it's basically like a little bit of a trap door. And what the trap door does is it basically allows you to preserve as much keratinized tissue around the healing abutment as possible. And as we've discussed in many of the implant lectures, that having good, healthy, stable, firm keratinized tissue around the implant is what is desired in order to sort of prevent long-term problems that can be associated with things like peri-implant mucositis and peri-implantitis. So what we're doing here is we're basically making that trapdoor incision. We used a 15 blade on a scalpel, and now you can see I'm taking one of my favorite instruments. This is a Woodson elevator. It's got this beautiful sort of almost 90-degree hook on the elevator head. It's great for just sort of pushing full thickness flaps away. We're going to get a little bit of light here. So now that we've got the tissue reflected, what we've done now is we've taken our 1.25 millimeter hex screwdriver. You got to be careful to keep a finger on this so that the patient doesn't fall, so that it does not fall into the back of the patient's mouth, and basically just counter torquing the cover screw off. And there's still some tissue here, so I'm using an explorer just to sort of help relieve some of that tissue. Getting that screwdriver back into place. There you go, now we got it. And that cover screw is nicely replaced, or removed I should say. And now I'm just finalizing my reflection of that flap, and what I'm trying to do here is adapt an impression coping. So this is a 5.7 millimeter impression coping. You can see that I'm just taking my instrument there just to sort of take those H incision flap pieces and just sort of help move them out of the way so that the internal hex of this open tray impression coping can seat down. And once we get it to seat down, we take our screwdriver, we basically screw it in place, and we're going to take a radiograph to make sure that it's seated. So I've got it in place. I'm holding it down with a finger. This is always a challenge, trying to get patients to open wide enough so that you can get the components in there to tighten these screws. They do make shorter screwdrivers as well. And so now that I've got that adequately tightened in place, you can also assess the lateral stability of the implant at this point. Once the impression coping is in place, just by bouncing it between the two fingers, it should be harder than the Rock of Gibraltar. So now we take a radiograph of that impression coping in place, and what you basically want to see here is you don't want to see a line. So you can see that this is seated down nicely on that implant face. So we'll go to the next video, which is going to show us how to take this open tray impression. So more or less, I like using these disposable trays. They're made by Teledyne Waterpick. You basically want to fit the impression tray in the mouth, and you want to mark with your finger sort of where the opening, or that open tray, that's why it's called an open tray. You got to make an opening. The actual implant transfer coping is going to pop out of there. So you'll see me just cut this section out right here. I'm using a straight hand piece, just a standard acrylic burr. Take some of the shrapnel off there, and you'll see here I'll put this impression tray in the patient's mouth, and didn't get all the shrapnel off. There we go, got it off now. We'll try this tray in. You can see that the screw port, we can actually access it. This is very important because as compared to the closed tray impression techniques, when you don't actually have that screw port open, you're going to have a hard time getting that impression tray out. You can actually pop it off the impression coping, but this can lead to lab errors. I'm just squirting some light body in there, and now I'm squirting some heavy body in there. And this is a product by Maxil. It's a heavy body fast set impression material. This is probably one of the fastest impression materials I've ever seen. I like using light body and heavy body. Some people say don't use light body because it's not firm enough to hold the transfer copings, that you can end up getting lab error and stuff. Well, the problem with not using light body is, have you ever tried taking an impression with just heavy body? Do it sometime. You get absolutely no detail on the teeth. And without detail, you end up giving your lab poor information. Poor impression, poor information. Lab doesn't get information, you get back a garbage product. So I like using light body. You don't have to use a ton of it. We use mostly heavy body because you want some firmness to the impression material around this transfer coping. But if you don't use it, you'll get a very, very poorly detailed impression. So we're just taking the bits of the impression material off that little port there so we can get the screwdriver back in there to pop this puppy out. This becomes the continual waiting game. So I'm just checking with my finger here. Make sure the patient's doing okay, doing a fancy turn. Grab my screwdriver. Ask the patient to open. So we're going to basically unscrew this impression coping, and the purpose of this technique is to basically pick up that impression coping, that transfer coping. Take the pin out, make sure the pin comes out. And more or less flip it upside down, make sure everything's been taken. As you can see, we've taken a beautiful fixture level impression using an open tray technique. I walk right over to, I usually stock these in my office myself. This would be the actual fixture analog, so an analog of the implant. And this is the secret to screwing these things in. You don't want these things to rotate, which is why I don't like the lab doing it. You get some rookie lab person, you end up getting a lab error. So you just screw it in like that. You hold the thing, and you don't hold the impression tray. And you saw it rotate around there in my finger. That tells you that the whole thing is in. So now what I'm doing is I'm grabbing a healing abutment, and what we're going to do is basically irrigate a piece of gauze with some chlorhexidine. You can also use the 0.25% sodium hypochlorite solution just to detoxify these things. It's also good to take towards the tissue. You don't want blood and stuff that's going to be sort of sitting on top of that implant face. That's going to when you close it up, it's going to necrose. At least if you have a clean surface there, it can help sort of clean things up a bit and make sure that when you pop these things off, sometimes you get that smell of things sort of like not smelling too good inside the implants. This can sort of help mitigate that. So what I'm doing here, I've basically put the healing abutment down as best I can. I'm taking my Explorer just to sort of move those little H flaps of tissue out of the way so that we don't end up compressing them. And this is kind of like one of those gum graft things too. You're sort of changing the soft tissue biotype around the implant. So you're taking that nice, healthy, thick connective tissue and keratinized tissue and moving it to the side. What's going to happen? This is all going to heal beautifully around this healing abutment. Now, it's very important. Some clinicians, what they actually do is they actually just do the H incision and put the healing abutment on. I like taking my impression on at the same time, but what's very important to do is make sure that when you do take this impression, that you let your lab know that you didn't really give it a healing time. In the anterior, I'll always just sort of put the healing abutment on, let it heal first prior to sending it off to the lab. In the posterior, I'm a little bit less diligent in this regard, and usually what I ask my lab to do is just sort of over contour the actual crown that they're going to give me, or contour it all the way down to the gingiva so we get a nice emergence profile. Usually these things are back in sufficient amount of time such that when you're actually going to be inserting this crown for the patient, it's going to actually have a beautiful emergence profile. Usually that tissue from that H incision quite hasn't healed up yet. If you're putting the crown in within about 7 days, usually when you insert it, that tissue will sort of puff away. And when these patients come back a few weeks later, the emergence profiles around these crowns are just absolutely gorgeous. So a post-op checklist here. So we have a post-op checklist. What you want to basically do is ensure that the healing abutment has been torqued in. There's nothing worse than having a patient tell you that they're healing abutment. Many times they don't say healing abutment, they say my implant fell out, which doesn't sound too nice. Number two, ensure that post-operative instructions have been provided to the patient in the form of care of the surgical site, oral hygiene rinses that need to be provided. In number three, that post-operative medications have been provided in the form of analgesics or antibiotics. Should there be any requirement for antibiotics? Usually at this point there really isn't, but should your patient require it for some reason, I'm putting that on the list here. Number four, ensure that post-operative follow-up appointments have been scheduled. So this would be for an insertion of their screw-retained crown. Number five, that the patient is fit for discharge with a responsible adult escort, assuming that some form of sedation other than just local anesthetic was used for the patient. And finally, number six, very important, ensure that the shade has been selected for the patient. Nothing worse than a lab calling you saying, okay, what's the shade that you want here? And number seven, ensure that the appropriate mesostructures that are going to be required to actually fabricate this implant retained restoration have been ordered. So this would be in the form of either the fixture analog, sometimes it's the actual abutments, the prefabricated abutments, or sometimes the USCLA abutments or the gold titanium abutments. Make sure that they've been ordered so that you're not sitting there delaying the actual processing of this impression and production of the prosthesis. So in this photograph here, you can see here a picture of basically that fixture analog inserted into the denture. You can see why, in this case, blue is the light body material, where that light body material really sort of helps us give you detail. And you can see by the implant there even, there's not really a lot that we really put in there. It's mostly heavy body that's holding that impression coping in place. So like I said, use light body. It gives you that much more detail in your impressions. And in this picture, you can see a close-up here. You want to make sure that fixture analog has been adapted appropriately, just so like we take an x-ray to make sure that the actual impression coping is sitting on the implant facing. We actually take a clinically, when you actually put this thing in, you want to take a close peek and make sure that you don't have a gap there. There's no micro gap, because this will lead to lab error. And in the next picture, you can see, in this case, we're just sending a UCLA abutment. So this is just one of those cast abutments that are going to be used for this particular 5.7 millimeter implant. And in this picture here, you can see a photograph of the actual model that the lab has poured up and created. So we have two pictures, one with the gum and one without the gum. When we actually take a look at the next photograph, what we see is a photograph of the crown seated. So you want to evaluate your crowns that come back from the lab without the gum, and then you also want to evaluate them with the gums to sort of evaluate what the emergence profile of this tooth is going to look like. And we're finally going to throw up just some final pictures of this case completed, so of the actual crown inserted and with the final prostheses, or sorry, the final restorations and stuff, Teflon plug and composite resin plug on the orifice of the UCLA abutment in place. So